From the Department of Orthodontics and Endofacial Orthopedics, we'll discuss about the cephalometrics in detail. So, the term cephalometrics is used to describe the analysis and measurement made on the cephalogram. So, coming to the introduction, the craniometry can be said to be the forerunner of cephalometry. The discovery of X-rays in 1895 by Röntgen provided a method of obtaining inner craniofacial measurements. So in 1922, Passini standardized the radiographic image by positioning the subject against a film cassette at a distance of 2 meters from the X-ray tube. In 1931, the Broadband in USA and Hamburg in Germany simultaneously presented standardized cephalometric technique using high-powered X-ray machine and head holder called cephalostat. So there are mainly two types of cephalogram is there. One is frontal cephalogram, another one is lateral cephalogram. So coming to the uses of the cephalogram, first one is the study of craniofacial growth. Serial cephalometric studies have helped in providing information regarding growth pattern of the patient, prediction of future growth, how much growth is remaining, and second one is the diagnosis of craniofacial deformities. Third one is treatment planning. Fourth one, evaluation of treated case, already treated case. We can evaluate the pre and post cephalogram. Next is the cephalogram can be used as an adjunct for estimation of skeletal age. So coming to the cephalometric landmarks, there are two landmarks. One is anatomic landmarks, another one is derived landmarks. So anatomic landmarks, these are the landmarks represents actual anatomical structures of the skull. And the derived landmarks are obtained secondarily from the anatomical structures. So the landmarks are used in the cephalogram should be fulfill certain requirements. So first one, it should be easily seen in the radiograph. It should be uniform in outline and should be reproducible. The landmark should permit valid quantitative measurement of lines and angles projected from them. So in this photographs we can see various anatomic landmarks of in the lateral cephalogram. First one, the orbital. As you can see in the picture, it is the lowest point on the inferior bony margin of the orbit. Second one is the chorion, the highest bony point on the upper marginal external auditory meatus. You can see in the picture. Next one is the sella. It represents the midpoint of the pituitary fossa or sella tacita. It's a constructed point in the mid-sagittal plane. Next one is the point A. It's the deepest point in the midline between the anterior nasal spine and the alveolar crest between the two central incisors. So it is also called subspinal end. Next, point B. It's the deepest point in the midline between alveolar crest on the mandible and the mental process. So it's called supramental end. It's the deepest point in the mandible. Next is the basion. It's a medial point of the anterior margin of the foramen magnum. Next is the Bolton's point, highest point at the postcondylar notch of the occipital bone. Next is anterior nasal spine, anterior tip of the sharp bony process of the maxilla. Next, gonion. It's a constructed point at the junction of the ramal plane and the mandibular plane. So you can see it's in the junction of the ramal plane and the mandibular plane. Pogonium, it's a most anterior point of the bony chin in the medial plane. Next is the menton. It is the most inferior midline point on the mandibular symphysis. Next is gnathion. It's the most anterior inferior point on the symphysis of the chin. Next comes the articular. It's the junction of posterior border of the ramus and the inferior border of the basilar part of occipital bone. Next is condylion, the superior point on the head of the condyle. Posterior nasal spine, the interaction of continuation of anterior wall of pterygopalatine fossa and the floor of the nose, making distal limit of the maxilla. So coming to the lines and planes in cephalometrics, there are horizontal and vertical planes. So coming to the horizontal plane, the first one is the SN plane. So it is the cranial line between the center of the sella turcica and anterior part of the frontonasal suture. It represents the anterior cranial place, sella to nasio, that is SN plane. You can see in the picture, the sella is marked and nasio. The line connecting sella to the nasio. It represents the anterior cranial base. Next comes the Frankfurt horizontal plane. It's a line connecting point chorion and orbited. That is FH plane, Frankfurt horizontal plane. Next is occlusal plane. It's a denture plane bisecting the posterior occlusion of permanent molars and premolars and extend to the anterior. Next plane is palatal plane. It's a point connected, it's a line connected ANS to PNS, anterior limit of the maxilla to the posterior limit of the maxilla. Tweed, Downs and Steiner's analysis, there are different mandibular planes. So in Tweed analysis, the mandibular plane is tangent to the lower border of the mandible. So in Steiner's analysis, it is gonion to gnathon. In Downs analysis, in gonion to mentor. That is the mandibular plane in for different analysis. So coming to the vertical planes, first one is the apoc line. It is a line connecting point A to pogonium. Next comes the facial plane. The facial plane is nasion to pogonium. The line joining point nasion to the pogonium. Next is the facial axis. It's a line connecting point PTM to the gnathium. Next is E plane. It's a point connecting PNS to the soft tissue pogonium. So coming to the analysis, first one is Tweed analysis. The Tweed analysis makes the use of three planes that forms the diagnostic triangle. The planes used are, first one is a Frankfurt horizontal plane, second one is a mandibular plane, third one is a long axis of the lower incisors. So in mandibular plane in Tweed analysis is tangent to the lower border of the mandible. The objective of the analysis include the determination of the position of lower incisor and evaluation of prognosis of the case. The angles formed by these three planes are, the first one is the Frankfurt mandibular plane angle. The angle which is formed by FH plane and the mandibular plane. The normal value should be 25 degree. If the value is increasing if the value is more than 25 degree, the inference will be the growth pattern of the patient will be vertical growth pattern. That is otherwise known as hyperdivergent growth pattern. Okay, if the value is 25, the inference will be the vertical, the growth pattern of the patient will be average growth pattern or normodivergent growth pattern. If the value is decreasing or less than 25 degree, the inference will be patient horizontally growing or hypodivergent patient. Next is the incisor mandibular plane angle, IMPA, the angle formed by the intersection of long axis of the central incisor with mandibular plane. It indicates the inclination of the lower incisor. So the normal value is 90 degree. If the value is increasing more than 90 degrees, the inference will be the patient's lower incisors are proclined. If the value is normal, it is upright, and if the value is less than 90 degree, the inference will be the patient is having a retroclined lower incisor. Okay. Next is the Frankfurt mandibular incisor angle. The angle formed by the intersection of long axis of the lower incisor with Frankfurt horizontal plane. The value is normal value is 65. So next comes to the Downs analysis. Downs analysis based on 20 Caucasian individual of age 12 to 17 years of age belonging to the both sexes. Downs consist of 10 parameters mainly. The 5 is dental and another 5 is skeletal parameters. So coming to the first one, skeletal parameters. First one is the facial angle. It is the angle formed by FH plane and the facial plane. FH plane is Frankfurt horizontal plane with orbital and chorion, and facial plane is nascent to the forehead. The normal value will be 87. So if any if the value is increased, we can say like the mandible is prognathic. If the value is decreasing, we can say like mandible is retrognathing.